So I am just going to jump right in. No geriatrics talk is ever complete without scary statistics about geriatrics, so here are my scary statistics. Basically, there are about 43.5 million caregivers in the US, and they, of course, provide mostly unpaid care, and often at the cost of their own jobs, their own wages, health insurance, benefits, Social Security, retirement, all of those things. And also at the expense of their own health at times. The economic cost is pretty frightening, and this was a heartbreaking statistic that I found while I was doing some research, that single women caring for their elderly parents are 2.5 times more likely than non-caregivers to live in poverty when they themselves grow old. And that's kind of, again, just another really scary part about, I think, entering into the caregiving world. The estimated economic value of our caregivers is immense. So it's estimated that they're providing, if they were actually paid, about $470 billion of care per year for their loved ones. And that's actually roughly the annual US spending on Medicaid. So if all of our caregivers were to suddenly stop caring for their loved ones, the US would essentially go broke. Compared to non-caregivers, caregivers who are caring for a spouse with dementia are also at risk of having more health issues. So things like infections, poor wound healing, increased risk of high blood pressure and heart disease. And this paper, my paper got erased, but Keikolt and Glazer in PNAS in 2003 thought that a lot of these things were mediated by IL-6 increase. So actual physical harm in providing care sometimes. Okay. So how do we care for our caregivers? Caregiving is challenging, caregiving is stressful, and it's incredibly challenging. So how do we help serve our caregivers and their needs? And I had to take a 75-minute talk and distill it down to a 10-minute talk. And so here's my one slide that kind of encompasses everything that I think, we can think about doing to help serve our caregivers better. So if nothing else, here it is. A couple things that might be helpful that I would recommend is if you are treating both the caregiver and the care recipient and they're both your patients, seeing them together might be efficient as well as synergistic. And then really treating our caregivers like members of an interdisciplinary team, just as we would our social workers and our physical therapists and other members of the caregiving team, because of course our caregivers are doing a lot of the heavy lifting at home. And have a lot of information, valuable information that they can share with us to help us tailor our care towards our patients. So encouraging good self-care and health-promoting behaviors in our caregivers is also important. It's sort of like that oxygen mask analogy that I often use, and I'm sure we all heard and use ourselves, but putting the oxygen mask on yourself before you put it on your kids or your loved ones who are seated with you on the plane. So you have to take care of yourself before you can be able to take care of others. And this is not just something that I promote to our caregivers as being beneficial or good for them. I promote it as something that's actually crucial to survival as a caregiver. Okay, and then these last 4 bullet points I think are all sort of palliative care concepts that I use a lot when talking to our caregivers. Facilitating communication is obviously crucial. Joint problem solving and shared decision making is a tool that we use a lot. Advanced care planning, attention to grief and bereavement, and empathy and compassion for family emotions and relationships and family dynamics that might be very different from our own and from our own experiences. So I would definitely encourage people to get a little training in palliative care because in palliative care you're often interacting with caregivers and patients and you see them as a unit and you treat them as a unit and as a team. So this is a really interesting article that I came across when I was reading through some of the caretaker popular media, and this is from the LA Times, and this is Patty Davis, who's Ronald Reagan's daughter. and she became his caretaker or caregiver after he developed Alzheimer's. And one of the things that she learned from caring for her dad is that caregivers, she felt, are rather neglected, actually. And so the article says, people would often stop and ask her, even strangers would ask her, how's your dad doing? And only rarely would someone ask her, and how are you doing? And I think that's very important. So she developed a support group for Alzheimer's caregivers to fill a need that she saw. And she said, people come to the support group for the first time and they're armed with all these facts about their mother or their father. They say they're on this medication, they were diagnosed on this date, and their doctors say this and that. And then I say to them, how are you doing? And there's this moment where they have to process the question, and almost inevitably, that's when the tears come. It might be the first time in a year or more, or ever, that they've been asked, but how are you doing? And I think that's really fascinating, because if you've ever been taking care of someone with dementia and their caregiver comes with them and you ask them, well, how are you doing? It's not unusual for them to break down and start crying, because I think it is something that we neglect to ask sometimes when our caregivers come in. So asking our caregivers how they are doing, I think, is a really critical first step in caring for our caregivers. It's really just kind of opening the door to good communication. So communication being key to kind of the interactions that we have with our caregivers and our patients. And there's a lot of misunderstanding that occurs, I think, in medicine in general, particularly in dementia and in interacting with families, providers, patients. Several of the problem areas that we often see may include diagnosis, prognosis, decision-making, and care preferences. So how do we address some of these issues? And again, I draw a lot on palliative care, but one of the things that I've sort of been doing in palliative care that I've noticed is a little bit of anticipatory guidance. And this is a tool that pediatricians use. And they define it as proactive, developmentally based counseling technique that focuses on the needs of a child at each stage of life. But can this model actually be employed to help us when we think about what our caregivers will be facing and how to help guide them through a neurodegenerative disorder, essentially? Because we all know sort of what the trajectory of dementia is and what it will look like. But when you are kind of faced with caregiving for a loved one, I think a lot of these problems, some of them can seem very immediate, and others you just have no knowledge about what is coming your way. So one of the problem areas oftentimes is diagnosis, like I mentioned before. So what can we do with initial diagnosis? It's usually when caregivers are entering into the caregiver role and they're coping with a lot of different losses. So they're coping with the loss of, to a certain extent, their loved one and who they knew and the identity of their loved one, because that's going to start changing and that's going to start transitioning, and also their role in their loved one's life. And when you start caring for your loved one and providing that type of care at home, you're oftentimes working less, and then you might eventually transition out of your job completely and into the caregiver role. So a lot of change. And again, a lot of us, our social world revolves around friends at work and work, because that's where we spend most of our day. So caregiving can also lead to a lot of isolation. So what can we do at this point? And we can provide some information on trajectory and prognosis and disease and start hooking people up with resources. Financial planning is pretty critical. Like I mentioned at the outset of this talk, caregiving involves a lot of financial loss as well. So when I diagnose someone with dementia, I oftentimes advise their family to seek help with financial counseling and an attorney. So you can start proactively planning. And at this point, your patient might also be able to help in that and some of those decisions. And that's also really important and critical. This is a huge one, safety. driving is always such a hot button topic, and in some places guns as well. Cooking, so, taking the knobs off the stove, worrying about your house burning down, medication management, all of these things we can, I think, definitely help with. And I think the more tools we provide our caregivers, perhaps the less frightening this might all seem. And it's just important for our caregiver safety as well that we are looking out for some of these things. Behavioral symptoms, as the dementia progresses, these often get worse. So agitation, aggression, delusions, the wandering. No easy answers. I think all of this is very individualized. We know a lot of the community resources that might help, adult day programs, and also considering eventually placement. Pharmacological interventions, I would say, are things that we reach for when we've exhausted other options. And then changes in care setting, also quite scary when you're facing when to send someone or when to have someone transition to a new environment. So is it time to place someone in a facility? That can definitely be wrapped up in a lot of feelings of guilt and fear and just the unknown. And then there's also the other transitions in care from facility to hospital, back to facility, or home to hospital to facility. So a lot of different adjustments to new environments, and we know what that looks like. We know and can kind of guide caregivers on how long it might take someone to adjust to a new environment. I often advocate for time trials when people are really struggling, and just some anticipatory guidance and education on delirium and sundowning, and helping people figure out when to consider sending someone to a different level of care. Okay. And then end-of-life care and beyond. This is, a lot of this has to do with, again, more education, even just recognizing that dementia is a terminal illness. I just recently learned that my mom didn't know that dementia is a terminal illness, and I've been practicing as a geriatrician for like 10 years. So a lot of people don't recognize that dementia is a terminal illness and what it looks like in the end. And how can we help sort of help our caregivers understand what that looks like? Because really at the end, we know that, once people start developing some dysphagia, get hospitalized with pneumonia or febrile illness, their 6-month mortality really jumps up to about 50%. So involving palliative care, or if you yourself feel pretty comfortable with your primary palliative care skills, and just getting a little knowledge about grief and bereavement as well. Okay. So things that you can do throughout the course of dementia that I think are very valuable that we often don't think about. So all of the anticipatory guidance stuff I think is very helpful and involves a lot of interdisciplinary support. And I think a lot of the things that I mentioned are things that you guys are already thinking about. But what can we do that we might not normally think about, and that maybe we're already doing but don't think about as ways that we care for our caregivers? And one of the things is just ask. So just ask, how are you doing, right? Because that's one of the things that I think is incredibly valuable. Listening and reflecting, that's a skill, a palliative care skill. Being present with our caregivers and acknowledging their emotions. Gee, I can see how frustrating this is. Normalizing, and I bolded this one because I think this one's actually quite critical as well, because a lot of times our caregivers will feel selfish, will feel guilty, will feel angry and frustrated. And not only are they feeling guilty about maybe the care they're providing or not providing, but they might also be feeling guilty about the emotions that they're having. And that's not something necessarily that they should be feeling guilty about. And it's something that we can help normalize for them, that, gee, anybody in your situation would be feeling angry about that. Anybody in your situation would be feeling frustrated. And I think the important thing to know about some of these things, which I know aren't often reimbursed or valued in our medical and insurance system, that I think are actually incredibly valuable. They're not just chit-chat. It's not just chatting with your patients. Like one of the social workers told me, it's not just chit-chat. It's actually very valuable work that you're doing to help support your caregivers. And then just remember to reassure your family caregivers that they are providing good care, because I think it's probably something that they're not hearing enough. They're very isolated oftentimes, and you might be the only one out there who's actually reassuring them and giving them props for providing the incredibly valuable care that they are providing.